I'd like to welcome everybody to this lecture. My name's Sterling Bryan. I'm the director of the Centre for Clinical Epidemiology and Evaluation, which is one of the core research centres within Vancouver Coastal Health Research Institute. And I'd like to say a very warm welcome to everybody for coming along. So thank you for your interest and enthusiasm for this topic and for making time on this beautiful Friday afternoon to come and spend an hour or so with us. This is our inaugural lecture. So for the centre, we're going to have an annual lecture, and we're kicking off this year with this lecture looking at saving publicly funded healthcare in Canada. And this is going to be our main stakeholder and community engagement event each year. So we're hoping that you'll be able to join us again next year, and we'll try and put on another excellent speaker. So we have Cam Donaldson, and I'm delighted that Cam agreed to be our inaugural lecture presenter at the centre. Cam, as everyone will have seen from his bio, is a professor of social business and health at Glasgow Caledonian University, and has been working in health economics for many years. He looks younger than he really is, so I can assure you that it's many years and longer than me. And I'm also very pleased to say that David Ostrow, the Chief Executive Officer of Vancouver Coastal Health, has agreed to say a few opening remarks. So I'm going to say nothing more other than to say we do have a reception afterwards, and we've ordered some food. So those who like food, then please stay and eat with us afterwards. We'll also provide some liquid refreshment, so please stay afterwards. So I'll pass over to David, and then we'll pass straight over to Cam, and then we're going to have some time for questions afterwards. But the reception also is an opportunity to ask questions and to engage in further discussion. So thank you very much for coming along.
Thanks very much, Sterling. Welcome to you all, and welcome to our guest speaker. Sterling tells me that this audience is not heavily into the clinical world of health authorities, and so he asked me to give you a teeny bit of insight into the BC system as it exists right now, and how we aim to provide the best care. And Professor Donaldson will discuss this in depth from the economic perspective. So he says, what is VCH? Vancouver Coastal Health is one of 6 provincial health authorities in BC. It's one of the largest. We have about 22,000 staff, 2,500 physicians, 5,000 volunteers. We're in 556 locations in the province, 13 hospitals, 3 diagnostic and treatment centers, 15 community health centers, and we serve more than 1 million people in the Lower Mainland, and for tertiary and quaternary care, the 4.x million people in the rest of British Columbia. Our operating budget is a little over $3 billion a year, so we're a pretty big company. We work to keep people healthy, and we provide services when they're sick. We help them recover. We engage in cutting-edge research to come up with cures and surgical techniques for today and for tomorrow, and we try to do all of this stuff simultaneously. In the context of today's lecture, we're the local body that's tasked with making decisions that directly impact the efficiency, effectiveness, and equity of our healthcare system. And these 3 elements are some of the major challenges that I face and that my team faces on a regular basis. For us, one of the biggest priorities is matching supply and demand. And demand is a money-eating dragon. We know that the elements of this demand, the elements of this dragon, are aging, population growth, inflation, health-specific inflation, and technology. So we also know that in order to tame this dragon, we have to use innovation, creative thinking, and exceptional people. We believe as an organization that we can balance supply and demand through innovation, and I'll give you a couple examples of what we're trying to do. We're trying to use performance-based funding to fund the work that we want to do, not funding us for just being there. We're trying to use new techniques to avoid hospitalization, to avoid residential homes, to keep people aging in place at homes. We're trying to reach out from both our community institutions and our acute care institutions to go into the homes of people with mental illness and provide their treatment in the home as opposed to in any kind of institutional setting. And then we're also trying to put together what some at Harvard would call value-added shops to provide that as a model of innovative healthcare delivery. Obviously, it starts with recruiting the right people, providing them meaningful work, and giving them the right tools. And we have spent an enormous amount of money over the last 5 or 6 years providing tools to our managers, our directors, our frontline people, giving them the best equipment and the most sophisticated decision support tools that we can. And of course, we measure their outcomes. When things go wrong, we try to support them. When things go right, we try to celebrate with them. And finally, what we've tried to do is to measure and measure and measure. We try to maximize our business processes by measuring things like productive hours, by measuring our staff mix, by measuring sick time and overtime and the cost per case and everything like that. We try to provide the best care by doing what's right and not doing what's wrong. We try to fund good care and penalize bad care. We're innovating with new models. We're providing in addition to what some call a standard solution-based model of care to the value-added model or the network-based models of care. And with that, we're working with C2E2. They're helping us with value-based allocation processes. They're helping us with the proms, and it's a very important partnership. So just as the partnership with our biological scientists is important for us, so is that partnership with C2E2. So Professor Donaldson, we welcome to Vancouver. We welcome the introduction of new ideas. And I have to tell you that we shamelessly steal from others those good ideas. And so we're very much interested in your dialogue today. Welcome.
Well, thanks for that welcome. I'd like to thank David and VCH and also Rob and the Institute and Sterling, in particular Sterling and his colleagues at the Centre for the opportunity to come to Vancouver and address you today, but particularly under the auspices of this inaugural C2E2 lecture. It really is a great honour for me to be here today in that capacity. Now, as an inaugural lecture, I've chosen what is a rather grandiose and wide-ranging title, so there will be, in the interest of time, there will be various points that I'll skip over, but please pull me up on those during the Q&A session afterwards or in the reception. Many people, I think, would see these two phrases that make up my title as contradictions in terms. And of course, I'm here today to try and convince you of the opposite view, that economics is actually key to sustaining our publicly funded healthcare systems. Now, before I give you a more detailed outline as to how I'm going to go about that, I just wanted to start with a quiz. And there's going to be quite a few of these throughout the presentation. So what I'd like to do is just take a minute to read this quote and think about the missing word. If you think you know what the missing word is, please shout it out. Obviously, it refers to a country in the sense of, it's not Britain, but if it was Britain, the word would be British. kind of thing. The quote appears on the website of a health ministry of an advanced economy, and its relevance to today's subject matter, of course, is that it makes the case for public funding of healthcare on grounds of economic efficiency. So that's going to be an important part of my argument. Any offers? Yeah, so who said Canada? Right, okay. It's Canadian is the word. So, no. So I'll come back to you on that later. So don't be too disconcerted by the fact that I'll come back to you later. So that position, the position of the Canadian government, is reflected in things like the percentage of healthcare dollars that are publicly funded. That is a phenomenon that is sustained over time, and it also occurs widely across the more advanced economies of the world, as illustrated here. So in broad terms, what we're going to do is start by asking the question about why that position still needs to be defended today. And then after that, what we'll do is then go on to address how that defence might be made from the perspective of economic efficiency, and I'll justify why I'm taking that position in a minute. And if we accept the arguments made, then the next questions that arise are, well, how might economics still be required to engender greater efficiency and equity in our publicly funded system? So that really involves asking how well are we doing with health economics, and how can we actually improve? And then obviously I'll finish with some lessons from Canada as well as lessons for Canada. So this stealing is a two-way process. And note that I'm using the word economics, not just, I'm not talking about economists particularly, because there are lessons for economists in this, hopefully for clinicians, managers of our healthcare system, and for the system more broadly. Okay, so let's go. So on the first of those issues about the need to defend this position, the Canadian government position, there are significant numbers in the general population who do not see public funding as free of threat. So here, obviously, we see one manifestation of that with the Raging Grannies at a joint event with Friends of Medicare, at one of their regular concert venues, the steps of the Alberta legislator, fighting Alberta's continued attempts to implement what we might call Ralph Care. Okay? For those of you who saw it, we had a segment celebrating the UK National Health Service, the NHS, at the London Olympics opening ceremony. Now, this was viewed as quirky, but good by, on the whole, by people in the UK, but not by everybody. These were the words of a senior Conservative politician reported in the press the day after the ceremony. It was also reported at the time that the Secretary of State for Culture, who was, in a sense, from a political side, was overseeing the Games, also tried to get this segment taken out of the opening ceremony. He lobbied for that to happen. His name is Jeremy Hunt, and in our Prime Minister's first major cabinet reshuffle since being brought to office in 2010, Hunt was moved from Culture to become our new Secretary of State for Health. So political threats are also very much alive here. Our academic colleagues don't necessarily help. This is a quote from Lord Skidelsky. Lord Skidelsky is best known as the biographer of John Maynard Keynes, so he's not a right-wing economist by any stretch of the imagination. But as when a lot of mainstream economists begin to dabble in health economics, they come out with quotes like this about how we need to inject a bit of market discipline in there through things like private insurance, access charges, greater competition to engender more efficiency. So our academic colleagues don't help very much either. Now, of course, there are moral and political arguments against these types of position, and who better to illustrate them than Tommy Douglas here, reflecting on how his boyhood experiences of illness and poverty influenced his views on healthcare. But Tommy's views might be seen as necessary but not sufficient, because detractors of public funding are too smart to take on such a Canadian icon. They make their case on the grounds of inefficiency and waste. And after all, that does have the appearance also of being a more objective argument. So what is also required is a counter-argument that's based on grounds of efficiency as well. And Canada, I think, has been lucky to have yet another icon to make such a case on a continual basis, because that's actually what's required. And that's Robert Evans, who I'm honoured to have present today, sitting here in the front row. I won't say any more about Robert. You'll get a rough idea of what I think about him by the number of times his name crops up in my presentation. My own views are articulated much more simplistically in this book that was published by Policy Press last year, Credit Crunch Healthcare. And I mention that not just to take the opportunity for a bit of shameless advertising, but also because I have 4 copies of the book with me. So for people who shout out the correct answer to these quotes that I'll be showing throughout the presentation, one of these will be your prize. So that's why I said I would come back to it. So whether that's an incentive or a disincentive to participate, I'm not really sure. Perhaps you can advise, because you might have finished it by the time. Right. A common starting point for thinking about the role of markets in society is Adam Smith's Wealth of Nations. Now, I use this quote not just to show the medics in the room what an old and august profession economics is, but because it illustrates Smith at his eloquent best, describing how markets act as an invisible hand, arbitrating between consumers who are all they're doing is looking after their own interests, and several producers who have to compete to keep their prices and hence their costs down to attract custom. And that all guides us to socially optimal outcomes, constituting minimisation of costs and consumers' wants being satisfied, and all with no need for costly and wasteful government intervention. It's just beautiful. So why don't we want this for healthcare? Well, not to criticise Smith. All Smith was doing was merely describing what he saw in a still developing and rapidly changing society. But theories subsequently developed and still propounded tend to be based on assumptions that leave out what we now know to be hugely important factors, and the most pervasive of which, in my view, is called the keyring externality. I say pervasive because I think almost all public policy dilemmas stem from the contention that we care about each other, and particularly about access of less advantaged people to what we might call fundamental goods, things like food, healthcare. Smith, in an even earlier treatise, as illustrated here, actually recognised this. It was formulated by Tony Collier, famous UK York-based health economist, now also actually working in Toronto, formalised by Tony in what I would see as one of health economics' fundamental papers in 1971. And the question that it then poses is if we care about access of others to fundamental goods, and in some senses are then willing to pay to effect that access, what is the best way of actually harnessing that willingness to pay? And at minimum, it presents a case for cross-subsidisation of people's income. So that's, in a sense, all that happens for a commodity like food. We can argue about the appropriateness of levels of income supplementation, but in a sense, that's all we do for food, and then we leave it up to people to make their own choices in the market, at least on the demand side anyway. And you could argue that food is a more fundamental good than is healthcare, so access to food is more important than is access to healthcare. So why do we go even further for healthcare than we do for food? So why in the UK do we have a national health service but we don't have a national food service? And that is due to further challenging attributes of healthcare which commodities like food don't actually possess. So I just want to skip through this, but really, in one sense, it's to do with the uncertain nature of the need for healthcare, to which less regulated markets will obviously respond in the form of insurance. Such markets being plagued by moral hazard, which essentially amounts to or manifests itself in problems in controlling the costs of the system. Secondly, there is the technical nature of healthcare, which rightly requires training and licensure to practice and therefore maintain standards to prevent harm. But that also has another side to it. It creates powerful professions, if you like, on the demand side. And these asymmetries and imbalances of power, I think, make it difficult to rely on the consumer, therefore, as the arbiter of value and the director of resource use on the demand side of healthcare. So it requires, on that demand side, some sort of collective action best effected by government. And that explains, all those arguments together explain really the existence of Beveridge and Bismarckian-type systems that pervade Europe, countries like Canada, Australia, New Zealand, etc. If you want a much more erudite and detailed explanation of these arguments, whenever I have an economist embarking on a career in the area of health, a must-read is chapters 2 to 4 of Bob's book, Strained Mercy, The Economics of Canadian Healthcare. The rest of the book is brilliant as well, but chapters 2 to 4 are a must-read of health economics. In a later work, Bob then went on to outline the key differences of our kind of public insurance systems relative to those that are based on private insurance. So ours are organised on the basis of groups with contributions based on income. Economies of scale are achieved in the sense of, in the US it's often reported, for example, that 1 in 4 of their healthcare dollars are spent on various aspects of administering the system. In Canada, I'm not sure what that figure is, but I would probably guess it's more roundabout, more something like 1 in 10 dollars, maybe slightly less. Universality, in the sense of 100% coverage of the population, is achieved virtually by definition. Cost control is achieved through various administrative mechanisms as listed there. I've added a couple of other considerations which in a sense are just my own kind of personal views. And one of the standards for all comment just really relates to the fact that I think an advantage of these kinds of system is that everyone is locked in to the one system. So those that perhaps are less able to articulate what they might want out of the system benefit from the fact that the vocal middle class, who are always pushing for higher and higher standards, are locked in to that system with them. We have to recognise there is a slight cost to these systems, and that arises from this notion of compulsion. But that has the compromise in most countries of people still being free. Once they've made their contributions to the compulsory part of the system, they're free to go on and spend their own income beyond that, which they could spend on private health, or private health care, except in Canada. Okay? Or is it except in Canada? So what I'm obviously referring to is the Canada Health Act, prohibiting privately funded duplication of services that are covered by the public system, in essence. Now, I know that currently in British Columbia, and obviously previously from some court judgments in Quebec, the boundaries of this are being pushed at all the time. I lived for 4 years in Calgary, so I'm familiar with Ralph Care. But I think that on the whole, most Canadians would support and claim that they have a one-tiered system. But even without violations of the Act, I think we have to question whether that actually is the case. And that's because, of course, of the 30% of healthcare spending that's not publicly funded in Canada. And inevitably, that is going to be multi-tiered with significant numbers of people with either no public or no private coverage for the items concerned. So that's my first challenge, is what should we be doing in Canada about that? And I know that BC perhaps is more generous than other provinces, but I would contend here that it's in my ignorance, that it's likely still a challenge here too. But for now, let's just round up this first part of my presentation by relating this tale of Alan Williams and the tale of the duck-billed platypus. This is an interesting analogy drawn, as it says there, by Alan Williams, who's in many respects seen as being the parent of health economics in the United Kingdom. He died about 4 or 5 years ago. He was also based at the University of York. And it appeared in a letter written by Alan in the early 1960s to the famous free market economist Dennis Lees, who had, in an earlier part of this correspondence, claimed that healthcare wasn't special because it shared characteristics with various other less regulated commodities. And using this example of the duck-billed platypus, Williams, as you've probably read it by now, says it has a duck-type bill, a furry body like a mole, it lays eggs, it suckles its young. Now, the type of analysis that's Dennis Lees has employed, would run as follows. Many birds have duck-type bills, and lots of animals have furry bodies, and as for laying eggs, this is common among birds and reptiles, and all mammals suckle their young. Therefore, the duck-billed platypus would appear to have no characteristics which differentiate it sharply from other animals. I hope my point is clear. But I think we're all agreed that the duck-billed platypus is a rather unique animal. So the point here in terms of healthcare is it's the comprehensiveness of market failure that makes healthcare different. And I think we could perhaps claim it to be the duck-billed platypus of commodities. Now, before I move on, I just wanted to say that some of what I've said is evidence-based. Some of it is not necessarily so. It's just arguments. I think they're arguments that would actually be accepted by the majority of health economists in Canada and in the United Kingdom. But they can be contended. And say if this was a mixed, audience, say with a lot of people in here from, say, the US, say US economists, they I think certainly would contend various aspects of what I've just said. Anyway, that's obviously not the end of the role for health of economics, and just saying, well, making the case for extensive government intervention and extensive government funding of healthcare, because, as we know, in our systems, claims will always outstrip the amount of resources that we have available to meet those claims on the system. So scarcity still exists, from which I think two main policy directions follow, or at least have followed over time. So the first, of course, is to enact different types of healthcare reform to enhance incentives for efficiency. So there's three aspects I just wanted to briefly cover with respect to this. The first is the case for trying to extend user charges in the system. The policy objective might be to try and curtail frivolous consumption, is a term that's often used. But I think the widespread use of them, and certainly the extension, I think, has been largely debunked in the literature, largely through the work of Bob, again, with people like Maurice Barer and Greg Stoddart from McMaster University, which I think, Bob, goes as far as back as 1979. You did a piece for the Ontario Economic Council. The basic point being that charges don't achieve what their advocates say they will achieve. They're inflationary and they are inequitable, and I'm happy to talk about why I hold those views afterwards. In large part, those statements, I would contend, are evidence-based, and evidence-based largely informed by Canadian researchers, people like Robin Tamblin, for example. Bob, Maurice and Greg, I think, were later compelled to refer to user charges as a policy zombie. So that is an idea which is intellectually dead, but it keeps coming back. Okay? The second dimension is the potential role of what we might call internal markets. So here, funding is still tax-based, But provider units, like hospitals, for example, they would then compete to win contracts and hence funding from health regions who now in an internal market would be taking on the role of commissioner or purchaser on behalf of their geographic population. This type of innovation has been based largely in Northern Europe, but in other countries as well. Canada has not gone down this line. I think that's probably the correct position to take, because in a sense, for all the cost and disruption caused, my own assessment is that at best the impact of these has been small, although positive. But actually, in fact, even being able to make that statement is difficult, because delineating any gains is severely challenging, because, as is often the case with such disruptive reforms, they tend to be accompanied by large increases in funding, so it's difficult to know whether the impact of the reforms is a result of the extra resources in the system or the re-disorganisation that's just taken place. And that's reflected in this quote from Alan Maynard and Karen Bloor in the mid-1990s, reflecting on the UK internal market reforms at the time. And these same points apply to claims made about recent UK reforms that have taken place over the last 10 years or so, and which have occurred alongside record funding increases for the UK National Health Service. Probably, I think, of relevance to something I'll say later, the most positive aspect in terms of changing things in terms of the UK reforms was this idea of general practitioner fund holding. So where general practitioners, some of you might call them family practitioners, were held budgets in order to buy drugs and hospital services for patients who were rostered with their practice. As I say, I'll come back to that. So the third aspect, of course, is remuneration. Largely, we're going to be talking here about physicians, and my standard position on this is it developed over time, has become that what is required by policymakers is a range of options to be available for adoption, depending on the objectives. So form should follow function. And those payment types may even be of a blended nature. That is, in a sense, they might all appear within one payment package for one particular clinical group, like family practitioners in the UK, who are paid by multiple sources, because each type of payment is trying to achieve different policy objectives. For example, a common position is that fee-for-service is bad, as illustrated in this quote. So this is part 2 of the quiz. Who said this? Come on, I don't want to take these books back. No, way before her. It's a famous figure in literature. Shakespeare. Crikey. Let's jump forward now. Sorry? No. Shaw. Who said Shaw? Not you again. Bloody hell. That's too greedy. Do you mind if I hold on to this? I might be able to think of another... Some people are just too clever by half, aren't they? Right, but thanks for that. Who am I to question George Bernard Shaw? But fee-for-service does have a place in the payment menu, especially if it's set at a sufficient rate to encourage activity that we might want to see a lot of, like, I don't know, vaccinations or something like that. But in broad terms, I think the key messages from the literature, the research literature on remunerating doctors, are basically that, yeah, doctors are human. They do respond to incentives. Supplier-induced demand exists, which, I think a lot of my health economics colleagues take great delight in actually showing this in papers. But actually, in some senses, the answer to that is, so what? The real question is, well, it shows that we actually have a policy tool to help guide behaviour. So what we need to do then is work out objectives and then design incentives accordingly. And those incentives could be fee-for-service, could be capitation, could be some form of budget holding, salary, etc. Now, one point I wanted to make before moving on is that voluntary schemes tend not to work very well, even in publicly funded systems either. So the basic problem here is that those with something to gain opt in, whilst those who don't have anything to gain, who are usually the people whose behaviour you're trying to change, don't opt in, because it's voluntary. But that's usually the way that these policies are sold to try and encourage participation. But in effect, nothing actually happens at the global sort of macro level of the system. US healthcare policy is riddled with failed attempts to control costs of this nature, which suffer from that basic characteristic. But also in Canada, I think health service organisations in Ontario were shown to suffer from that particular problem. So this area of remuneration, I think, remains an outstanding problem in Canada, which won't be news to you for me to say that. I mean, my perception is still that virtually all physician remuneration is fee for service. Is that correct? And to me, this balance is pretty much out of kilter, probably the most diplomatic way of saying it. But I think not only that, I think that the way the system is set up means that physicians, okay, people talk to each other, so physicians are involved in that sense, but when you look at it structurally and in terms of financial flows, physicians are kind of disconnected from the system, and I think that remains a major challenge, is to achieve more integration in that respect. The second main direction that follows, so after healthcare reform, of course, is if we're still trying to engender greater efficiency within our publicly funded system, is of course the use of economic evaluation, which you might recognise more in phrases like cost effectiveness and cost benefit analysis. And of course this is all about trying to use these methods to aid better decision making in healthcare. And I think economic evaluation studies have attained a high degree of sophistication and commonly appear in top medical journals and elsewhere in the literature, and the methods have formed the basis of activities of most health technology assessment agencies, of which there's been a proliferation around the world. So it might seem odd as an economist to stand here and list some of these types of challenges. But let's try them out. Try them out on you. So first of all, we'll throw out a little challenge to physicians. So stripped bare, economic evaluation is very simple and sort of two-dimensional, at least in conceptual terms. So any decision to change the way that care is delivered is going to impact on health outcomes. And ideally, we would hope that a new innovation relative to current practice would lead to an improvement in those health outcomes. So that's A as on that list. But outcomes might stay the same, or they could, unfortunately, get worse. One thing that economics adds, of course, is the dimension of resources or cost. So, again, any decision to change the way care is delivered will impact on cost. And again, well, the best situation here is, other things being equal, is that costs will be saved, i.e. decrease, but again, they could remain unchanged, or they could increase as a result of a new innovation. So, part 3 of our quiz. Bob, you need to shut this person up here. This quotes a leading physician who was in favour of both of these dimensions of outcomes and cost being the driving force for clinical decision-making or clinical policy-making. Any ideas? Sorry? No. A leading physician from the UK? Archie Cochrane. Was that Stuart? I would hope you've already bought something. Okay. So the challenge really to physicians, bringing these dimensions together, well, the best place to be in this matrix, of course, is in an A1 position where health outcomes are improved and costs are saved. That would be unambiguously whatever the innovation is that's been evaluated should be adopted. And there are another two slots there with ticks in them where at least there's an improvement on at least one of those dimensions and the other one remains the same. Correspondingly, there are 3 crosses. So whenever I work with, say, a clinician scientist who's interested in health economics, the first thing I do is get them to try and list all the interventions which they're currently providing in their service and see if they can place them in this matrix. That tells us 2 things. One is, where is there evidence lacking with respect to showing cost effectiveness or cost benefit of these interventions? And secondly, if there's anything in the 3 cells that have crosses in them, it raises the question of why you're doing this. So any implementation scientist, I think, will tell you that the biggest discoveries to be had, the biggest gains to be had in health are from basically implementing evidence that we know about now, rather than going for big discoveries in the lab. So I would say that a challenge to clinicians, particularly young clinicians, is to, when you're thinking about, if you're thinking about going for a clinician scientist award, then go for like something in the area of health services research or health economics, because that's what's needed in order to get these big improvements and help us sustain our systems. Right. The second area is a challenge to economists, and another contribution of economics, of course, with respect to health outcomes, has been most obviously in developing the quality-adjusted life year, or the QALY, to try and combine in a single measure key dimensions of life years with different degrees of impairment in which these years might be spent. That's been highly successful, but over the years, I think several challenges have come to light, which I think really, health economists, I think, need to sort of take a step back and think, well, are we actually conducting or implementing methods which are really in line with societal preferences? So various questions can be raised here. Are all QALYs equal, for example? And there are some examples just listed there that might raise some questions in your mind as to whether indeed all QALYs are equal. What about other attributes? A lot of people have preferences over what we might call non-health attributes of care, like location and invasiveness, which QALYs don't really do well at actually capturing. What about more minor or temporary states? Let's say someone could be in a state of severe pain, and I've given this a conservative estimate of it would be a drop of 0.3 in sort of quality of life terms. So let's say severe pain is 0.7 on a 0 to 1 scale, where 1 is full health. So to avoid that pain is a gain of 0.3, and let's say they would be in severe pain for half an hour. So to turn that into QALYs, we divide it by 48, because there's 48 half hours in a day, and then by 365 to turn it into the sort of years element. That results in 0.0002 QALY gain. So if that intervention to avoid that pain costs, say, $20, that's $1 million per QALY. And we shouldn't be providing that, but there's a common intervention that I have in mind that is provided on an everyday basis that fits that profile. Yeah, so anesthesia for what? Yeah, dentistry. Right, I won't run all the way up there, because Sterling's worried about time. That can be a supplementary question. Please collect this at the end. Thanks for that. There are alternatives, things like willingness to pay methods that I've been involved in myself, discrete choice experiments as well. But I think a big thing about what's happening with HTA at the moment is to do with this question of applicability at the local level. So it's often common in the United Kingdom for NICE, the National Institute for Health and Clinical Excellence, to make recommendations based on some estimate of cost per QALY. But for local funders, primary care trusts for the moment, although it's changing, to claim that actually there are other priorities on their list that they would see as having greater value for money for their local population. So we have to ask, what and who is national or provincial health technology assessment for, and to what degree is it actually relevant and being used. There's also a problem of lack of outcome data, and in that sense I was really pleased to track down this paper by Kim McGrail and Sterling and others, obviously authors based here in the city, where you're making a case for the development of patient-related outcome measures and also showing, outlining a plan for how that could actually be implemented. Right, my third challenge is to managers. And really the issue here is about how are you going to manage austerity, disinvestment. These are words that are now becoming regularly used that you couldn't use in healthcare language 10 years ago. And to aid this, economists, in partnership with healthcare managers, have developed what we might call an economics-based approach to needs assessment. And all it does, in a sense, is try and operationalise these 5 questions which are listed here. So in any context, we can ask the question of how much resources have we got, how are we currently spending those resources, and then we have various questions, but essentially amount to saying, are there some things we might want to do more of with that cash-limited sum? And if so, from where are we going to get these resources, and what are the implications of that? Can we be somehow more efficient in the sense of providing the same services to the same level of effectiveness at less cost? And if we are maxed out in that technical efficiency sense, should we take resources from an area of care that isn't providing as much health gain per dollar spent as some of the things that are on our wish list? And those kind of questions can be asked within programs, like, say, diabetes care, or for example, or across the spectrum of, say, a health region. And they essentially amount to what economists or health economists have called, these are questions that underlie what's called program budgeting and marginal analysis, for those of you more interested in the jargon. And what people like Craig Mitten and C2E2 and myself and several others, Stuart Peacock as well, who's now based in the Cancer Agency, have been working on over the last 20 years, is to think about, well, how can we turn these questions into a management process? But it's not new. So our final question is, who said this? So here's a person who, to give you a clue, in Victorian times was offered an enhanced budget to look after a hospital in London. She turned down the enhanced budget, just giving you another clue there, because she wanted to see how she could get more efficiency out of the system with the budget that was currently available before going cap in hand and asking for more. Florence Nightingale. As with many lessons in evaluation of healthcare, we go all the way back to Florence Nightingale. So, in terms of lessons to date from this work that Craig and Stuart and others have been conducting, just trying to sort of summarise all that, it's about 20 years of work, but you can go to reform documents, any country, anywhere, any system in the world, and they'll be talking about things like how the new system is going to adopt a balance of care approach. It's going to be about effectiveness and efficiency. It's going to be evidence-based. It's going to involve communities and other stakeholders, and resources will follow patients, and will even protect frontline services, whatever they are. But no one ever says how that is going to be achieved, and that's what a lot of that work has been about. It's been about standing back and trying to understand complex health organisations, and instead of health economists standing on the side and saying, why don't you adopt our wonderful, say, cost per quality model, try and understand those organisations and how we can fit the economics to them. And the lessons that have been learned are broadly these: that it's possible to eliminate waste, move towards things like standard working, and scale back on a least value basis. Clinicians and managers, I think, want to work with more systematic frameworks, generally know what to do, but often it's about not being allowed to get on with it. More often than not, the best use is every patient knowing and having a current best individual care plan. There will then be occasional trade-offs, but not many, so the use of these kind of frameworks is actually minimising the pain of things like disinvestment, not encouraging it. And there's much more detail on how to go about these processes in a paper led by Stuart and the BMJ 5 years ago. And then very recently, how Craig has been beginning to work with VCR on this issue of difficult decisions in times of resource constraints. So beginning to get to grips with this issue of how do we actually take these programme budgeting and marginal analysis principles and apply them to the issue of disinvestment. So just summing up, these are the lessons from Canada. I mean, the system works. It's world-class by any standards. It will always be politicised, partly because of ongoing federal-provincial relationships and the co-funding that comes with that. But I think it's fair to say that Canada's led the way on introducing and maintaining, as I say, a world-class publicly financed system, led the way against consumer-led financial reforms, not introducing in internal markets. And I think in research terms, you have the best evaluators, system analysers, and researchers on priority setting, not just in the country, but right here in this province, and indeed in this city. But what might I do, just to try and be a bit more controversial, what might I do that's not done now? And, I mean, there are still some elephants in the room that I've not discussed, and we can perhaps talk about them afterwards. But after all that, I just have these 4 recommendations, and I wouldn't underestimate the challenges of some of the things that I've listed here. But I think we have to think of ways of restructuring the system and its incentives, making it more integrated, if you like, to deal with chronic disease management. So the idea, in the UK, we've got a system that's still set up on a 1948 model when the NHS was introduced. You got sick, you went into hospital, you got cured, and you came out again. Didn't always get cured, so you might have come out in a different way. But that's the kind of model. But that's, I think, what we have to get away from. But then there are questions, well, who's best placed to lead this system? If it's going to be physicians, say, in primary care, where the vast majority of patients have their first interaction, are they in a good position in Canada to lead that system? Can we also integrate that kind of leadership with budget responsibility? It might also require patients, it's not listed here, but patients actually rostering with family practitioners, general practitioners. Are Canadian citizens ready for that, and do they perceive that as a restriction on their behaviour? It would require things like blended payment systems of the sort I referred to. And what about the 30% of costs that aren't currently covered by public funds? I mean, do the arguments that I outlined about market failure, do they justify public funding for other initiatives that could begin to cover that 30%? Initiatives like pharmacare, and other National Forum of Health recommendations that were made as far back as 1997 when I first came to Canada. And I noticed that Steve Morgan recently wrote from UBC recently wrote a paper kind of reflecting on how pharmacare somehow didn't make it into the original kind of Medicare package. And I think was also arguing that we need to now be having a rethink about that, because it's more efficient to do so, not just more equitable. It would be less costly and fairer. What about the role of health technology assessment? Well, all I'd say there is that this might be a UK problem as opposed to, say, a provincial or national one here in Canada, but I just wonder who's really driving the agenda of our health technology assessment organisations in the United Kingdom. It doesn't seem to be commissioners or regions, but it seems to me that NICE and commissioners are the only 2 organisations that are supposed to be acting on behalf of the population. So why don't they do it together? Why isn't NICE's agenda set by NHS commissioners? I think much more economists need to be working with, rather than on, healthcare managers as well as systems. And also the same, I think, applies to the public. We need to be thinking of new methods for allowing us to establish what the public think is socially relevant in priority setting and decision-making contexts. And just to finally put that point out about clinician scientists again, I think we need to rethink the notion of the clinician scientist. So eschew the lab. Forget about swapping one white coat for another. Come to somewhere like C2E2 and as a clinician and learn a lot more about health services research and health economics. And that way, I think, we can save our publicly funded systems. Thanks for listening.
Great. Well, thank you very much indeed, Cam and David. We are going to take some questions. I know that we're at 4:30 and or close to 4:30, and some of you may need to leave. If you are leaving at 4:30, then grab a roll on your way out because there is food. But we are going to have a time for, so we'll probably try and give ourselves maybe 5 or 10 minutes for some questions. So if you have got questions, then let us know. Rob McMaster, who's the director of the Research Institute, is actually going to kick us off, and then we'll have a few other questions. But we won't keep you all evening. Don't worry.
Well, first I'd like to thank you for a most stimulating lecture. Even though I've never even taken economics, it was clear the importance of it. One question that we're all not faced with, but we're challenged with and working towards is implementation of commercialization, implementation of research into whether it's the private industry, or clinical implementation. With economics, how can you describe maybe some strategies that you feel have been successful in implementing either a new model or some of what the last hour that you've been talking about, where it really has been implemented into clinical care, the health system? Because I think the British system is very similar to it's different but similar to the Canadian system.
Yeah.
I mean, the one thing that I don't think we need to address is that the Canadian, I think there's 11 or 12 health systems within Canada. Each province is separate, but even within each area, are there some strategies that over the more recent years that have shown to be successful?
Yeah. From a research perspective, I think it partly goes back to some of these points. It's about working with, rather than necessarily on the sidelines, and that's certainly been a big lesson from the work that we've undertaken on trying to instill economics as part, as a management process. I don't know, Stuart, or I don't know where Craig's up there as well, would also attest to that. I just think that is key. I really like this idea of the clinician health economist in a sense. Some of my health economics colleagues see that as a threat to us. But actually, I think what that allows is health economics to touch so many more clinical areas than any little core group of health economists could actually do on their own. It amazes me the number of young clinicians who come to me and say, I'd like to do health economics and study health economics in my area. Quite quickly, they can become the world leader of the health economics in their area, which is a good incentive for them as young, ambitious clinicians, because it's been untouched. And I think that kind of hub and spoke model of groups of health economists at the core, working with various clinical clinicians in their area of practice, I think is a very useful model as well. And I had experience of that in Calgary as well, so that's not just in the UK. But it requires the clinicians to have a rethink about what they want to do as scientists.
Take that one, and then this one, and then there was one at the back, I think, as well. Should we take all three questions and then give Cam a chance?
Yeah, that's a good idea. Yeah.
I wondered if it was opportune at this point to broaden the frame of reference somewhat, particularly as you were thinking about chronic disease management. Economics lens should go.
Okay. Yeah.
On the same line, knowledge, self-knowledge, and health often changes behavior. I think of that health knowledge and other orphan along with
Okay, yeah.
And then right to the back.
I guess my comment. I'm wondering about, we've got increasing attention.
The advantage of having several questions is that the speaker can choose which ones he wants to answer.
Well, they're all the same. Right, well, do you remember when I said there was an elephant in the room, or a bunch of elephants in the room? That was the one that was most in the back of my mind. So, my talk was restricted to talking about the healthcare system. So that's why I didn't bother to. I did have a slide on health inequalities, but I thought it was too tokenistic just to have one slide. So I took it out a couple of days ago when I was preparing. I think it's a major challenge to health economics, to health research in general, is that despite these world-class systems that we have, and I would say that that's undoubtedly the case in Canada, the United Kingdom, is the growth in the health gap between richest and poorest. My home city of Glasgow, Michael Marmot, in his latest review of health inequalities published in 2010, showed that the gap between best and worst off in that city of Glasgow has now grown, in life expectancy has now grown to 28 years. Okay? So, this is not good. But my only excuse is that wasn't that wasn't the subject matter of my talk today, but there's a huge elephant in the room. You might have noticed my current position on the first slide, which is Yunus Chair in Social Business and Health. So that was a switch for me a couple of years ago in 2010 from working as what you might say a regular health economist for 25 years to a new position where we were trying to think about the idea of, I don't know if you know who Muhammad Yunus is. He won the Nobel Peace Prize in 2006 for his efforts to eliminate poverty from below, from the ground up, largely through his promulgation of the notion of microcredit, so microloans to the worst off people in society. He delivered a lecture at our university a few years ago, and as a result of that, and when he visits cities like Glasgow and Vancouver, he doesn't take in the highlights, he takes in the other parts of the town, and he was shocked by what he saw. So what he's trying to do is to bring Grameen Bank, his bank, to the most deprived parts of the city of Glasgow. And my chair was created to try and build an evaluation framework around that. So trying to work on things like you're saying, where we're trying to enhance people's control over their own lives, if you like. So think about things like microcredit as a complex community-level public health intervention and try and evaluate it on that basis. So I myself have been moving to some degree towards that agenda over the last couple of years. Was there Steve up there in this one as well?
So we'll take two more and then we'll close. So yeah, was it? And then yeah.
I was recently reading a worker that was talking about presenting a model for big medicine. Large private enterprises, and sort of postulating this as largely in the context of a private healthcare system. Areas that will translate over.
Yeah, sure.
My question is about data. I'm a data geek, and I lack of health outcome data. Provider agencies to invest in the development alternative data sources that allow us to address.
Okay, right. So the first question, I mean, the answer is a bit of both. I mean, I do think there are lessons that can be learned from those approaches with respect to, the ability of some organisations in the United States, for example, to be able to, integrate what they do in one organisation and in that sense be able to serve well those whom they're serving. Part of the problem, though, I think, is that tends to take place amongst, there are probably some Americans in the room who could comment and maybe contend what I'm about to say, but it tends to take place amongst the people being served tend to be those who are better off and are somehow able to respond and demand those types of more integrated services. If we can transfer those to our type of system and our context without abandoning all the good things about our system and our context, all well and good. Data availability, God, that's a huge one. As an economist, I tend to go back to trying to work with healthcare managers, with clinicians on these types, those lists of resource-based questions that I put up, in the sense of saying, well, if we're reviewing any particular type of services, are these the right? Do you think these are the right questions to be asking? And in most cases, people can't contest them. They are based on the supreme logic of really basic economics. The question then comes about in implementing those, and that then does become a big challenge. But the thing is, if we're already working with the right set of questions and the right set of principles and developing frameworks around those, the managers and the clinicians then begin to think about, well, okay, that didn't work particularly well this year, but it shouldn't just be a one-off exercise. How can we do it better next year? So the data that begins to follow, at least, is based on the right starting point, recognition of scarcity, and the frameworks and data that are needed then in order to manage that. That's about the best I can do, I think, with that very challenging question.
Great, thank you very much. So, just to say that the lecture has been recorded and will be available on our website, so c2e2.ca. And it'll be freely available, so if you want to use it for teaching purposes, then please feel free to download it and make use of it. I should say a thank you to everyone who's come tonight. Thank you very much for coming along and making this a special event. Thank you very much to all of my staff who have helped in preparing for this event, put a lot of work in. Thank you very much to David Ostrow for giving the opening remarks. And finally, a very big thank you to Cam Donaldson for an inspiring lecture.